myself. So hopefully that'll go smoothly as we.
Great.
Ryan, you want to do sound check?
Yeah, Ryan Sexton here. Can you hear me?
Yep.
Susan, I'm just checking my audio. Can you hear me?
Yes, I can.
And I'm sorry, who's the court reporter today?
Good morning, it's me, it's Maggie.
Oh, hey, Maggie. How are you?
I'm one of yourself. Good morning, Mr. Owen Foster.
Good. Nice to see you. Sean, do you have everyone you need?
Let's see. Yes, we do. We have Dr. Ryan Sexton, my Chief Medical Officer, Andre, our Chief Financial Officer, and then John Kaczynska, our board chair, is also on.
Perfect. Great. How are you all?
Good.
Very good.
Okay. So Sean, I'll call the meeting to order here in a minute. But once I do, I'll turn it over to our counsel to swear everyone in and just identify yourselves for the record and affirm that you swear to provide truthful testimony. And then after he swears you in, you can just take it over, and we'll have about 45 minutes or so for your presentation. If you need to go a little longer, fine. And then we'll turn to board questions after that. Sound good?
Sounds great.
Great. All right. Well, thank you all for being here. I'll call to order the Green Mountain Care Board's hearing of August 26th. This morning, we have a presentation on the NVRH fiscal year 25 budget. And I'd like to thank you all for coming, and I'll turn it to our counsel, Mark Hengstler, to swear you all in, and then we'll turn it over to you. Thank you.
Hey, good morning, everyone. So I'm going to go ahead and read the oath to be prescribed for witnesses. What I'll have you do is I'll read it, and then I'll have you each state your name individually and say, "I do." That way the court reporter has everybody's name and the oath for each person. So I'll go ahead and read the oath. Do you solemnly swear that the evidence you shall give relative to the cause now under consideration shall be the whole truth and nothing but the truth, so help you God?
This is Sean Tester. I do.
Andre Bissonette, I do.
Ryan Sexton, I do.
All right, you are sworn in. I'll go ahead and turn it over for your presentation.
Okay, great. Let's see. I'm going to try sharing my screen here. If I do share. Okay, tell me if you guys can see that. You can. Okay, great. Fantastic.
Yes.
Wonderful. Now I'm going to put it, see if I can put it into presentation mode. Okay, there we go. Oh, and I lost my own screen. Okay. Let's see if I can, okay, there we go. You guys still see that, right?
Yes.
We can.
Okay. Fantastic. Somehow it bounced down to the back. Okay, there we go. All right, we're on a roll now. We're ready to go. Good morning, everybody. I do have a few introductory remarks, but first I do want to quickly review our presentation agenda, introduce our speakers and the leadership team, and then we'll roll into my introductory remarks. So first off, what you see on the agenda here today.
You're on. You got Sean. You got the last slide that's showing, not the first one.
That's weird. Okay. Do you see the entrance? No.
No, No, the last slide is the one
Sean, we
that's
see, yeah, we see slide 22.
Oh, for heaven's sakes. Okay, hang on. Okay, if we come back to just this, do you see, let's see if we come to, do you see our opening slide now? All right. I'm not
Yes.
going to worry
Yeah.
about presentation mode. We'll just go with this. This will get it done. Okay, so first off, as I said, our presentation today, we're going to go through our overview, talk a little bit about our mission, vision, and values. I have some introductory remarks, and then we'll get into our budget summary. We'll go over our FY25 priorities. We'll look at our proposed performance against the Green Mountain Care Board benchmarks, look at budget risks and opportunities, our capital investment plan, and then we'll be ready for your questions. So today I have with me John Kaczynska, our board chair. John, if you could just say hello or raise your hand and wave so that people know you're on, that'd be great.
Yes, good morning. Great to be here. We really appreciate this opportunity to present our budget here proposal. Thank you so much. Great to see everyone.
Thank you, John. And then as you just saw sworn in, our three presenters are myself, CEO of the hospital, Andre Bissonnette, our Chief Financial Officer, and Dr. Ryan Sexton, our newly minted Chief Medical Officer. Although he's new to that role, he is a veteran of this institution, having been the ED director here for over a decade. Kind of in the background, a lot of people went into supporting this, our budget and our presentation today. We do have our senior leadership team who supported us. That's Sharon Burrows, our Chief Information Officer, Diana Gibbs, our VP of Community Health Improvement and Marketing, Betty Ann Guakin, our Head of HR, Chief HR Officer, Laura Newell, our VP of Operations and Medical Practices, and Joe Pimentel, our Chief Nursing Officer. I do want to give you a quick overview of NVRH, and I am aware that the Green Mountain Care Board, I probably know this very thoroughly, but we're an independent, nonprofit, 25-bed critical access hospital. Our ED averages nearly 14,000 encounters per year. We have 734 employees, an incredibly robust cadre of volunteers, but we're especially proud of our student interns and the 60 people who we have provided training support to over the last year, helping them with their career goals. And finally, I want to remind you all about our service area with a population around 30,000, but of course, we're also supporting the well-being of many more, including people who come to us for care from New Hampshire. The Loan Institute gives us an A rating for both our community benefit as well as social responsibility. Now with that primer, I'll get into my opening remarks. So first off, Chair Foster and members of the Green Mountain Care Board, we want to thank you for taking the time to thoughtfully consider NVRH's budget this year. We're incredibly proud of the work our team has done to prepare for today, and we're likewise incredibly proud of our staff and caregivers who work tirelessly to meet the healthcare needs of this community. Why is this budget so important? This budget underpins our commitment to sustainability and in meeting our strategic priorities to provide healthcare services that our patients need. That is our why. I'd like to acknowledge the impact the recent floods have had on our region. For those of you in the Montpelier area, I know you're no strangers to the damage caused, but after two 500-year flood events in July alone, we're facing months or years of roads and bridge rebuilding, as well as business closures, community members, even staff who have lost their homes. Ensuring local access to quality care is even more critical as this community recovers. Like much of Vermont, we have an aging demographic. Residents 65 and older comprise nearly a quarter of our population. According to Oliver Wyman's trajectory, by the year 2030, this number will swell to over 20% and be over 35% by 2040. Additionally, our community experiences greater disparities compared to the rest of the state. Higher rates of poverty, lower educational attainment, lower household income, we're about 20% below the statewide average. Greater chronic disease prevalence and a prevalence of health behaviors that pose greater risk for disease onset. Coupled with the historic flooding and aging housing stock, transportation barriers, and an increasing prevalence of mental health and substance use disorders, you can see that the drivers of health in our area are important areas of focus for NVRH. To support the needs of our population, we must take a holistic approach to wellness by ensuring local access to clinical care, as well as supports for the social determinants of health that have the greatest impact on someone's health. And while we work hard to support our community reciprocates through philanthropic giving, bolstering many of our programs. Through collaborative efforts and a commitment from our community, we've developed a career advancement program to develop the workforce that we need now and into the future. We are breaking ground on the West Wing expansion project, creating modern and efficient spaces to better meet the demands of our community. And leveraging congressionally directed spending, we've recently added a more conducive space for folks experiencing mental health crisis in our emergency department. We've adopted new technology to reduce the administrative burden on our providers, to increase productivity and reduce burnout. We've leveraged the HRSA-funded Rural Health Redesign Center to create our new strategic plan and to conduct a thorough analysis that will enhance our revenue cycle. NVRH is well positioned for the next phase of Vermont's healthcare reform. Local access to care is an equity issue, and we are committed to working with partners like Northern Counties Healthcare and North Country Hospital to ensure the needs of the Northeast Kingdom are being met. We'll talk a little bit more about that later. But each and every day, we seek innovative opportunities to leverage resources, partnerships, and technology to enhance the care we provide for our community. We do that because we care for our friends, families, and neighbors. We are committed to this community that we call home, and we are committed to ensuring that they have access to the care they need right here in the Northeast Kingdom. This is our why. Now, I want to take a few minutes to highlight our new strategic plan, which we implemented over this last year. Our mission is to improve the health and well-being of all, and our vision is providing exceptional care in an environment where our patients, community, and employees can thrive. Now, on this slide, you can see our values and strategic goals. I'm not going to go through these in detail with you, but these are driving our priorities as we have prepared for the FY25 budget. And those FY25 budget priorities include improving access to high quality and affordable care, strengthening our partnerships, ensuring financial stability, controlling expense growth, and workforce recruitment, retention, and development. You'll see these themes woven throughout our presentation. Now, with that primer, I'm going to pass it over to Andre for a budget summary.
Here's a snapshot of our budget summary from 2023 actual to 2025 budget. Go to the bottom line, you can see it's rather consistent with a projection of 2024 of a loss of just under $1 million. That projection was submitted developed back in April and May, submitted July 1st. That projection still holds. When you combine that projection with our ask for 2025 budget, it's almost a zero bottom line. Our NPR growth, we're asking for 3.9%. We're calling it unadjusted. If we adjust it for our pain clinic, it comes down to 3.28. Our pain clinic services have expanded. Part of that is in result to North Country Hospital's closing of their pain service. So in reality, those aren't new volumes or dollars that are flowing through the state of Vermont. Those are already being absorbed through North Country Hospital. They're now coming down to NVRH. Roughly 50% of our pain patients are coming from the North Newport area. Our rate request, 4.5%, and an operating margin at 0.7%. Again, the $900,000 operating margin.
Great, thanks, Andre. We're going to spend a few minutes here talking about access to high quality and affordable care. And there are a few things that I wanted to go a slightly deeper dive on for all of you. Andre did just speak to our NPR growth, and that in part being driven by our pain clinic and expansion of services there. That to us is a real success story. As Andre alluded to, a couple of years ago under the prior regime, not the current CEO of North Country, they unilaterally decided to eliminate pain management services. We were not made aware of that change until we started seeing a jump in referrals. So we have worked hard to adapt and adjust, and we just recently added a second clinician to our pain management program, and that's reflected in this year's budget. This is in part, part of our solution to the opioid crisis that we have in these communities, right? We need to make sure that people don't turn to either prescription drugs or other means to control their pain, but they get in and they get those services so that they can lead the best possible life they can. And I'm saying this as a patient of our pain center. I struggle with chronic neck and back pain, and what they have done to support me has been truly transformative for my own life. So I know viscerally just how important this is to people who need those services. Wait times and referral lags. And I think if you look at the data for NVRH, it's a little bit of a split tail here. For one thing, the success, some of the things that are going well really revolve around access to primary care. And this is because of our own success in recruiting and supporting providers that are level set to meet the community and our population, but also through partnership with our federally qualified health center, Northern Counties, who likewise are really successful at meeting the primary care needs of the communities that we both serve. So access in that space is good. What you do tend to see is in some of our specialty care clinics, there is a longer wait time for access. Neurology, sometimes urology, pulmonology. These services, we tend to have a single provider or a physician and an APP to provide services in our community. We try to size that appropriately, but sometimes that's challenging for a small community like ours, to find the right specialist who wants to live here in the Northeast Kingdom, but also, let's say we ideally need 1.5 neurologists. It's hard to find that extra 0.5. But this is where I think the shift in our relationship with North Country really comes into play. And we're going to talk a little bit more about that later, but I was describing how North Country unilaterally eliminated services a few years ago and how we reacted to that. Our partnership with them is very different today. And we're working together on services like specialty care so that we can make sure that both our communities are well served by those programs. We'll talk about that in a little bit. Improving access to care through increased provider productivity. We have a CDI program, clinical documentation improvement, that we implemented this past year. We expect that to start to bear fruit in the coming year. That helps us better capture the hard work that our providers are doing and make sure that we're appropriately billing for it. And also adding tools to improve efficiency. So we are in the middle of a pilot of an AI app that helps providers in the practices build their notes so that they can better focus on their patients and reduce the amount of administrative work they have to do on the back end. We believe that in the coming years, as those AI tools evolve, that's going to both enhance productivity as well as lower burnout for our providers and staff. And finally, we are continuing to work to create more efficient schedules to maximize provider availability as well. Next up, we have quality with Ryan Sexton.
Thanks, Sean. NVRH is committed to improving access to high quality, affordable healthcare. Here we report our quality indicators, including our HCAHPS, Press Ganey patient experience, top box scores, hospital readmission numbers, 72-hour ED returns, interfacility transfer numbers, our mental health visits, average stay, length of stay for mental health patients, and our clinic no-show rates. So as you can see, we are at or near goal for all of these, and we'll continue to focus our efforts on improving these metrics. I'd like to highlight our continued success in reducing avoidable emergency department visits. So while we're close to our goal of less than 10%, I think it's important to acknowledge we've significantly reduced this number from around 30% in 2018. That's when we initiated our Call Your PCP First marketing campaign. So as I'm sure you're aware, Dr. Merman, you're aware, we can never turn away patients who are seeking care in our emergency department. But our team works really hard to arrange primary care follow-up for patients who present without established primary care. We also give patients as many alternative options for urgent and emergent care as possible. So for example, we maintain open spots in our primary care clinic in the daily schedules to accommodate same-day visits. We continue to work on creating efficient provider schedules, as Sean noted, to maximize visit availability. This includes weekend visits. It's also worth noting that our medical practice visit volumes have steadily trended up over the past 5 years. We also continue to offer express care. This is essentially first come, first serve primary care. It's embedded in our primary care clinics as opposed to most urgent cares, which are detached and separate from primary care. This is in our own clinics and also in partnership with Northern Counties Healthcare. We also report here increasing use of telehealth consultative services, including telepsychiatry, teleneurology, telecritical care, and telepharmacy, as well as increasing primary telehealth visits provided by our medical practices. The power of this service cannot be understated. We're seeing it every day. Our lead primary care behavioral health specialist shared a recent telehealth encounter that she had with a young man who was being treated for anxiety and depression. The patient had been under a lot of stress at home and at work, and he works long hours. Fortunately, has been able to negotiate with his employer for the time and privacy during work to attend telehealth visits. This has allowed him to get the support he needs in a way that's both convenient and sustainable for him. And without this remote option, he likely wouldn't have been able to access the care he needs. This is just one example. We will continue to leverage telehealth services to improve access to both primary and specialty care for a rural patient population, but also acknowledge that many of these services are provided at significant cost to NVRH and without reimbursement. I think that speaks to our focus on quality. I'll turn it over here to Andre.
Looking at the RAND data that Green Mountain Care Board staff and Elena has provided, we compare NVRH to the Vermont average. The graph is pretty self-explanatory, with NVRH being the orange bar and the state average being the blue. When you look at across all of the different core services, inpatient, outpatient, professional, NVRH is in good standing compared to the Vermont averages. We're going to continue to focus on pricing and affordability as we look at our charge master and our revenue cycle review, which we'll talk about a little bit later. I think this slide is self-explanatory. One of the things we started doing this summer, was looking at what I refer to as the Act 53 website. This lists the top 20 charges in many different areas of our hospitals throughout the state. It has each individual hospital listed as well as the average. Some of the areas we look good in, we're low, like office visits and CT scans, and MRIs, we look a little bit on the high side when you compare ourselves to average. One of the things we're going to be doing is looking at how can we move any of those high charges closer to average, and do we need to raise some of our prices that are lower than average. But this is a site that is maintained by the Green Mountain Care Board, I believe, and or actually Vermont Department of Health, so DEVA. It's been out there for a long time, but this is something we're going to start focusing on to make sure that we're in alignment with the state and the rest of the hospitals. Next slide, Sean.
Okay, this may be my favorite slide of the whole deck. When we talk about healthcare reform in the state of Vermont and the direction that I believe we need to go, and that I see the state moving in, we're only going to be successful as we work together and collaborate. And that's what this slide really describes. I want to start with some of our ongoing partnerships because we have a deep history of working collaboratively with healthcare and system partners to meet our community's healthcare needs. Littleton Regional and NVRH have had a long-standing partnership to provide ENT and allergy services here in our community. We share providers back and forth, and that's been a very successful program. And it means that people don't have to travel farther away, especially for those allergy shots. We have worked hard as a community to develop our accountable community for health. I know you've all heard us talk about this before, but NEK Prosper has been tremendously successful in enabling the social services organizations within our area to better collaborate and coordinate so that we can best meet the social drivers for health needs within this community. NEK Prosper's priorities focus around access to food, housing, financial well-being, mental well-being, and physical well-being. And we continue to go from strength to strength with NEK Prosper. One thing that we've done this year under the leadership of Diana Gibbs and Michael Costa at Northern Counties Healthcare is we've collaborated to develop our regional community health needs assessment. Now, each individual hospital needs to have their own health needs assessment that is done every 3 years per statute. But many other institutions do similar work. And since we're all trying to collaborate on these services, we came together to develop our own community health needs assessment this year. Northern Counties, our local regional federally qualified community health center. Their areas of focus are primary care, dental care, some behavioral health, but they're also the home of Carolina Home Health and Hospice. So clearly they're an important part of our care fabric in this community. We've had very long-standing positive relationships with Northern Counties, but the most recent one, and I know Ryan just talked a little bit about our Express Care model, that was done in partnership with Northern Counties. It's kind of a co-branding program where they manage the Express Care Clinic in St. Johnsbury. We manage the Express Care Clinic in Corner Medical. And then over the last year, they also partnered with North Country Hospital to put an Express Care Clinic in downtown Newport. Now, the thing that we love about this is the common branding. It really is that walk-in primary care that gives people access where they would not normally have access to it. I know, again, speaking my family with teenage kids, we use Express Care more than I'm comfortable admitting, but it is so incredibly convenient. And that is the main driver why we've been able to push down those avoidable ER visits over the last 5 years. I can't imagine with our current ER volumes what we would have done if we hadn't deployed the Express Care program a couple of years ago. And finally, I'd be remiss if I didn't mention our two incredible partners in our tertiary care facilities, both Dartmouth Hitchcock Medical Center and the UVM Medical Center. Again, longstanding partnerships and great relationships with both institutions. DHMC, we contract with for our cardiology services here at this hospital, as well as some telehealth services. UVM, we've had a longstanding relationship for pathology services. We do have new opportunities coming up that we're continuing to develop. The first two are around, we're building EMR interfaces between Northern Counties and ourselves and Dartmouth Hitchcock. What that will enable is better flow of patient information between our institutions, because after all, these are all shared patients between our institutions. And then we're also working with Dartmouth Hitchcock, which runs the Norris Cotton Cancer Center, essentially on our campus, just a little ways down the hill from the hospital. And they came to us about a year ago because they needed to put a lab in the cancer center to enable cancer patients who are receiving treatment in our community to be eligible for clinical trials. We saw this as a great opportunity to work collaboratively together. So we are implementing a satellite lab at the cancer center. This is a real win for them and our shared patients, because those patients are now eligible for those clinical trials. But it's also a win for us because our lab was really struggling to keep up with the volume of lab services we're providing here at the hospital. So this is actually also going to improve access for our own patients right here under the hospital's roof. And then I want to provide a special focus of our relationship with North Country Hospital. This, I can't tell you, it's been a breath of fresh air working with the team up there over the last year and a half. The collaborative spirit that we've developed and the high trust we have with each other is really, it's really going to help us turn the needle and make sure that we are collectively serving the entire Northeast Kingdom. And when I say the entire Northeast Kingdom, I know you've seen us all on a map. You know where Newport is. You know where St. Johnsbury is. But I want to talk about the patient that might be coming from Canaan, Vermont. Canaan, Vermont to Newport is just about an hour drive. You essentially have to tack to get there. There's no easy, straight way to do it. Canaan to NVRH is more like an hour and 15 minutes, maybe more. And that's on a good weather day. You know, this is a large and remote area that we are collectively trying to serve. And the only way we're going to do it is by working together. I already talked a little bit about how our approach to specialty care services. Those conversations are ongoing, but I feel confident that working with the team at North Country that we're going to be able to develop those services in a way that builds resiliency. You know, if you have multiple providers in one program, you lose a provider or a provider has to go out for a while, it's much more stable if there's another provider in that program as opposed to a single provider. It's going to improve stability and sustainability while also improving access for our patients and ensuring that that care is available locally, like we know we need to do. We're also sharing other resources as well, partnering on training programs, sharing educational resources, as well as policies and procedures that we can now develop together so that there's some consistency amongst our hospitals. Plus, it's kind of ridiculous. As a critical access hospital, we need a large set of standard policies and procedures, as do they. It's crazy for both of us to kind of do that work separately when it's much more efficient if we can just share some of those resources. I also want to acknowledge that this type of engagement doesn't just happen in isolation. It really takes a commitment from the leadership of both institutions to work together to make this stuff happen. And that's why Tom and I have committed to bringing both our boards together for a board-to-board meeting before winter sets in this year, just so that we can talk about our commitment to this type of collaboration and how our boards can support those efforts. Our goal is to initiate or pilot at least 3 new collaborative initiatives in this next fiscal year. So I hope next year I can come back to you and share where those success stories were. And now I'm going to turf it back to Andre to talk about financial stability.
Yeah, and as we mentioned earlier, you know, we've been a financially stable organization for many years with a positive margin. Again, our projection is just under $1 million loss for this year. We're looking to get back to that stabilization with a positive margin for next year that supports our request, both for NPR and rate increase. The one change on the balance sheet we did want to highlight, it's our other long-term debt. We've embarked on a significant infrastructure project with our ER renovation, pharmacy renovation, lab renovation, all areas that desperately need this additional space. The long-term debt that we're embarking on is with the USDA. It's a little bit unique. It is USDA. It's a 36-year commitment for the debt at 3.75% interest. So quite a bit different than a traditional bond offering, and it actually enables us to stretch that debt at a reasonable annual payment amount. Next slide. Again, positive bottom line in 2025 is critical. Achieving the Green Mountain Care Board benchmark, strengthen the balance sheet ahead of pending increase in debt service payments. And below is our key financial indicators. If you look across all the indicators, they're fairly stable except for the 1 year with our operating margin. Days cash on hand, probably a AAA rating if you went to bond market. So all of these indicators have been stable. We plan on them continuing to be stable. Next slide. Expense growth. We looked at the cost per adjusted patient day trend. That's an indicator that the Green Mountain Care Board staff have looked at. If you look at 2023 through our 2025 budget, it's actually quite stable, with an increase from 2023 to 2025 of just 2.6%. That's quite low compared to the national inflation increases that we've been seeing. The cost savings that are in the 2025 budget is pretty significant. How we've achieved that through contract renegotiations, looking at our contracts, either renegotiating them, canceling them, taking a different approach, purchase service reductions, service contract eliminations, supply pricing, which also with supply pricing comes zero-based budgeting, and zero-based budgeting that we've implemented in this budget cycle. There's major categories. These are the major categories that we've actually implemented zero-based budgeting. We asked for the detail of what makes up that line item for purchase service, contract service, and minor equipment. The supplies, we look at what we've been running on an actual, not budget to budget, and what do we really need in our budget for those supply items. Next slide, please.
Did it come up, Andre?
Yep. So this is in addition to controlling our expense growth. As Sean alluded to, we've embarked on some initiatives this year. Strategic planning. That was the FY24. That was, would have cost us $75,000. We engaged with RHRC for revenue cycle review and actually got some funding from the SHIP grant. Both of those initiatives would have totaled $125,000. In next year's budget spend, information services, these are some huge numbers. Fortified and WAN firewalls, that's related to our cybersecurity. And we've got a grant through FEMA for $150,000, which is to help secure our physical clinics in Orleans or in Lyndonville and in Lyndonville on both sites for $150,000. That's to help with patient security and staff security. So the total funding we received was just under $750,000 for those initiatives. That's a huge amount that we did not have to write a check for out of our own operating account. We got the funding for that. Next slide, Sean. Again, zero-based budgeting for 2025. Staffing levels, particularly in the clinical areas, the clinical areas use a staffing matrix. They look at what they need every day of the week, every shift of every day of the week for all year long. Travelers and locums, those get plugged into those staffing matrix. Purchase services, as I said, we asked for detailed spends on purchase services as well as service contracts. When you look at our administrative growth versus clinical growth trend per the Medicare cost reports from 2022 through 2025 budget, actually pretty flat overall with a slight reduction from 2023 actual down to 2025 budget in the administration area. Next slide, Sean.
All right, Ryan's up.
Yeah, I'm going to talk about staffing. So we're committed to workforce recruitment, retention, and development as a strategic plan priority. Developing our local workforce is important to reducing overall staffing costs. And we've recognized the significant personal investment that's necessary for individuals to advance their education and clinical careers. And for some, this can be insurmountable. So in response, we've developed a successful program called the Career Advancement Program, or CAP. This program provides an opportunity for our frontline clinical employees, as well as non-clinical employees, to enroll in a clinical education program while at the same time maintaining employment at NVRH. The program is structured so that employees work less hours in their current job and are paid for their time spent in school. In addition, NVRH covers the cost of program tuition and fees. In return, the employee commits to NVRH to practice clinically upon successful completion of their program. This program is largely, almost entirely funded through philanthropic contributions. We're really excited about the success of this program to date. So we started with the medical assistant program and have 6 employee graduates this year. We have 4 LPNs who will be starting nursing programs, RN programs in the fall. So we expect this program to demonstrate long-term benefits by developing and retaining a local clinical workforce. I'd also like to highlight our new nurse preceptor program. So while we're not a large academic institution, we recognize the importance of providing training opportunities. We've developed with Simplify a preceptor program for our new RN graduates, and it provides hands-on focused training to enhance clinical skills and confidence. This program also provides leadership training for our current staff to become preceptors. We currently have 8 new RN graduates participating in the program. And by fostering professional growth and helping new graduates succeed as they enter the clinical world, we expect this program to enhance nursing recruitment and retention. Professional development and education is a priority in our strategic plan. We've committed resources and established timelines within our plan to ensure our goals are achieved. In addition to the CAP program and the nurse preceptor program, we have abundance of internal learning and development opportunities. We also offer college loan repayment benefit to all levels of employees, as well as the more common physician loan repayment benefits. Tuition assistance is also available to all levels of employees, up to $4,000 a year. I want to repeat, NVRH is committed to workforce recruitment, retention, and development. Next slide. Our efforts are paying off. So we've had some significant recruitment successes. We hired 27 RNs in 2024. We converted 2 nurses to permanent status and decreased our travel utilization to now just 5 for this coming October. And those are on board to allow for new grad training and onboarding. We're projecting only needing 2 travelers in January 2025. So this is a significant movement in the right direction and no small feat given continued national trends in healthcare workforce shortages and also local housing challenges. The transition away from a reliance on temporary traveling staff to a permanent local workforce will have a positive impact on our operating expenses. We're also focused on staff retention. So in 2024, we've demonstrated an 86% overall retention rate, and we attribute this high number to the professional development opportunities just mentioned, and also our committed clinical leaders who continue to work to improve culture. You know, we learn from our mistakes, we listen to our staff, we involve our staff in creating solutions. We also offer competitive compensation and meaningful benefits. Next slide, and I'll turn it over back to Andre.
Yeah, and again, NVRH performance to Green Mountain Care Board benchmarks. The operating margin that was laid out, the benchmark was a positive operating margin. We're coming in at 0.7% operating margin for the 2025 budget. Our NPR growth, as we discussed earlier, the target was 3.5, our actual is 3.9, but if it's adjusted, it's 3.28. Below is the calculation for that adjustment. We have roughly $750,000 of NPR growth related to our pain clinic. And if you back that out, we're at 3.28. And as a reminder, again, those additional volumes and NPR for the pain clinic are already in the state of Vermont. That's not necessarily new business. That is business that would have been being seen up at North Country. Next slide. Okay, our commercial growth rate benchmarks 3.4%. We're coming in at 4.5. Part of that is to strengthen the balance sheet and to break even with a combined 2024 and 2025 operating margin. This is after significant 340B improvements, after revenue cycle improvements, as you saw before, significant expense reductions. With all of this, we're still asking for a 4.5% rate increase, as it is necessary to meet all of those objectives. Our capital investment. We break it down into what I call like routine capital expenses, this top section. It's about just under $2.4 million. The significant capital investment that we talked about earlier, the CON project, which is our ED addition, and some non-CON projects. So these items fell outside of the CON purview, with a total capital budget of CON and non-CON $18 million, and total spend for next year of 20.5. How we're going to get there? We've got a bridge loan in place for 8.4. We've got philanthropy of 4.5, and that's not just a goal. We have that money, as well as our own investments of 5.3 million, come up to that $18.2 million. So a significant embarkment for the organization and our investment into the future.
Home stretch.
Risks and opportunities. Some of these are the same for probably every hospital in the state, much less the country. Risk, inflationary pressures. We've hopefully seen the highest inflationary pressures behind us, but that is still a risk. Workforce challenges tied into housing challenges. Our fringe benefits. Utilization of self-funded health insurance plan due to demographics. We've seen some pretty significant increase in our healthcare spend, like many of us throughout the state and the country. Healthcare reform efforts, changes to 340B. That's always under scrutiny at the federal level, and just overall industry-wide risks. Our opportunities, we've implemented a new payroll system this spring. It's called Paycom. Looking to leverage that to get better line of sight to the largest expense item on our income statement. So looking for potential efficiencies and labor management out of that. Continued looking at expense efficiencies and potential expense reductions. Again, we've gone through some pretty significant revenue cycle reviews, the entire revenue cycle, as well as our charge master review. So looking to leverage the outcomes of those reviews. Continued 340B revenue enhancements, additional productivity improvements, and growing our partnership with North Country Hospital.
Before we jump off this slide into questions, I do want to come back around to the housing issue. And I know this is not unique to us in the Northeast Kingdom, but boy, does Vermont have a housing crisis. And it really is impacting, it's both impacting our communities where people cannot find a safe, comfortable place to live, but also it's impacting our recruiting. We've lost, despite our successes with recruiting, we've lost so many good candidates who want to be in Vermont, who want to contribute to our economy, who want to serve our community, but they could not find a place to live. And I know it's outside the purview of the Green Mountain Care Board, but we all have a responsibility to project just how big a challenge that is for all our communities and our health systems. And with that, pass it back to the board, and we're ready for your questions. Thank you. I'll stop.
Thank you all very much. You can leave it up if you want, Sean. People may have questions about it. Sometimes that happens. I'll open up to the other board members. Okay. Great. Any board member questions for NVRH?
I can hop in with a good number of questions. Thanks for the presentation, the submission. I was up there for the community meeting recently. Sean, I drove up past your road the other day. I was up in the Northeast Kingdom and is pretty impressive how wet everything is still there compared to the central part of the state. It's just, I mean, it was raining, but the ground is still pretty saturated. So
yeah, Dr. Merman, you're right. I mean, there's no place for the water to go. It's just unbelievable. And I personally, I kind of live at the epicenter of the recent storm that hit our area, and it's like living in a war zone. I mean, it's just unbelievable.
yeah, I was just driving up towards Burke. You could see a house sitting off the side of a embankment in the Brook Road there. That just the bottom of Brook Road was that Hunger Mountain Road or something. But anyway, so thanks. Let's. I've got a whole bunch of questions there. I don't know if they're fairly thematic. They were pulled out of the submission and reviewing the documents. So I think I'm just gonna. They may feel a little bit scattered, but. So one that I noted was that you mentioned that you guys were able to reduce your cost. This case mix adjusted decrease in cost per patient by 2.8%. And I was curious if that has an impact on your cost-based Medicare reimbursements.
Andre, do you want to take that one?
We have not seen a significant impact on that, Dr. Merriman. I think because of the adjustment and how the cost report works, we really haven't seen any kind of a significant impact on that.
Would you expect to see that over the next couple of years, or?
I don't think so. You know, especially as we try to keep our costs low, it's cost to charge ratio. So if we can keep our charges down and our costs down, the ratio doesn't change that drastically over time.
Okay. With regards to the pain clinic, I have a few questions on that. So one is, when did the pain clinic close at North Country? You said that was a couple of years ago.
Yeah, that's a good question. I don't know exactly when it closed, but it was before, it was under the previous CEO. It's got to be at least 2 years ago.
Okay. And then do you have any idea the payer mix of the pain clinic? Is it sort of a similar distribution to the rest of your operation, or is it skewed in one way or another?
We've looked at that. Going back to the business plan that we built, it's pretty similar to the rest of the organization, surprisingly enough. A lot of these folks have had chronic pain for a long period of time. Dr. Dent's had some pretty good success getting those patients off of opioids through his management program. So I don't think it's any particular payer. I think it's pretty much mirrors what NVRH's payer mix is.
Okay.
But Dr. Merman, while you're on that subject, I do want to mention, it's interesting. So Dr. Dent joined us. He came from Dartmouth, and he was, I don't know if he was the lead physician for Vermont, but he is a very active participant in Vermont's RETAIN program. Are you familiar with that program?
I'm not.
Okay, it's grant funded, but the goal is to work with people who may be on disability and help them get back into the workforce. And it's kind of linked up to our pain management program. So that portion of his work is grant funded, and it's a really nice melding, again, enabling people to live their best possible lives.
Thanks. I actually sat in on a hour-long meeting this summer, now that you mentioned that was on that topic, but I forgot the name of the Vermont Retain, but it was an interesting program trying to move people off of disability back into the workforce through occupational medicine work. It was great. So when I was looking through your budget, it looks like really kind of very subtle utilization increases throughout the various inpatient, outpatient budgetary items. Some of the budgets that we're looking at this year have pretty substantial utilization increases. What's different about your region that the utilization looks fairly flat, or just very modest compared to some of the other regions? Or do you have any insight into that?
Yeah, Yeah, I don't know. I haven't really compared what the other regions are doing. I think historically, most volumes in rural areas historically have been relatively flat. It's not like we have a competitive nature through Vermont that we're gonna, aggressively seek additional volumes, and it's not like our population is exploding. We did see an increase last year. I think it was more driven from pent-up COVID demand, but we've seen that that's come back down to more of a historical type of level, especially in a lot of the specialty areas like surgery. I think a lot of people were putting their surgery off, and we saw some significant increases last year. Those have come back down. So compared to other hospitals, I'm not 100% sure where they're getting that from, unless they're a potential border state. And again, the only other real increases that we've seen are from our pain clinic, which we know where that's coming from, with North Country closing their pain service up there.
Yeah, I was just trying to consider, with all your strategic goals of improving access and reducing outmigration, whether or not that would impact your utilization more than you're projecting if you're successful.
Well, if you go back to that partnership and our collaborative efforts, we're hoping to pilot at least 3 programs this year, but it's too nascent for us to really build that into the budget. So we did not make any budget assumptions based on those pilot programs. The one you do see is the additional provider in our pain clinic to support that demand, and that's a good reflection. You may see that in next year's budget, but it all depends on our success in working together.
I saw that your total patient days is budgeted for around 6,245. It's around 6,000 total patient days. Do you have any idea of what your average daily census, inpatient census is?
Yeah, it hovers, depending on which one you're looking at. The acute census hovers between 13.5 and 14 for an average daily census.
Okay. My speaker just got a little weird. Is my audio weird?
We can hear you.
Okay. All right. And then that's your acute census, and then do you have like an observation census in addition to that, or
yeah, so it's about 13.5 to 14 for acute. Overall runs around 15.
Okay. And then I noticed that your transfers, at least in the 22-23, looked like there's a pretty big bump there. And are there services that are you unable to admit those patients locally? Is that why the transfer bump is? And there's been a change in services that's led to that increase in transfers, or is it some other factor?
I don't know.
I'm going to let Ryan take that, but I think, overall, we wouldn't transfer a patient unless it was services that we couldn't provide here. And since Ryan lives in the ER, I'll let him speak to that as well.
Yeah. So Dr. Merman, I think part of that, we mentioned that we're bringing on 20 some new nurses and new grads, and we've got these new grad programs, and we're trying to enhance their skills as they come on board. I think, that has limited at times our inpatient capacity, to be honest. And I think, we would expect that, as new staff come on board, we may be able to hold a few more patients internally. That being said, the great majority of transfers, we try to keep everyone here who we can. These are patients that need higher level of care that we can't provide. It may speak to the acuity of the presentations, I think, more than anything else. And I frankly don't know why that trend exists.
I was curious if you've had a chance to maybe it's just a aberrant bump for a year, although this year kind of looks like it's sort of staying up there. If you've had a chance to do any analysis to see if you were to add services there, if there would be a reasonable benefit of adding those services to trying to keep the patients there, and what those services would be.
Yeah, I think we're I don't think we're going to have a cath lab, right? We're not going to do ERCPs. And so there are limitations to what we can do here and expand as much as I'd love to. That being said, yeah, I think where we have one urologist, for example, he can't be on every single night. And so as we look to partner with North Country and share some specialty coverage, I wonder if there's opportunity there to maintain some patients that would otherwise be transferred out.
That would be helpful, I think, wouldn't it? Yeah. I mean, we all would love to be able to keep patients closer to home and not drive them around the state. So, talking about the RAND pricing, it looks like you've had a chance to look pretty thoroughly at the RAND pricing. One of the challenges that occurs with the RAND relative pricing is it's based upon your Medicare reimbursements. So RAND figured this out a little while ago and came up with a standardized pricing. So that a critical access hospital has relatively higher Medicare reimbursements, which means that the denominator is high. So the numerator can look quite, even if it's high, it can look like it's not as big of an impact. So if you were to look at NVRH on the relative RAND pricing, which is relative to your Medicare reimbursement, it looks quite different than it does in the standardized RAND pricing, where they just eliminate the Medicare reimbursement impact into this. And in the standardized pricing, NVRH is actually fairly high. You're one of the top few states for outpatient, top few hospitals in the state for outpatient pricing, and for inpatient pricing, you're sort of on the higher side. So I guess if you think of yourself as actually having high outpatient prices, which is what it looks like in the standardized pricing now for both RAND 4 and 5, how do you think about that with regard to your budget and your overall pricing and requests?
Dr. Merriman, I think we probably need to better understand and work with your staff on how that actually would work. Because we always think of how we compare to Medicare being cost reimbursed. And I think, and this is the part I don't fully understand, is that standardized pricing basing it on if we were reimbursed at a PPS level? Which
it's commercial pricing. So they're not considering your Medicare business at all. They're just looking at the commercial prices. Yeah. So the RAND pricing is all commercial pricing. And so they have the Medicare relative pricing, which is really helpful. So if you're in a region and you're comparing a bunch of mid-sized PPS hospitals to each other, it's a very intuitive way to think about that. But when we get into a place like Vermont, where we have critical access hospitals who all get reimbursed different amounts of Medicare, UVM, which is an academic medical center, we have and a sole community hospital, Rutland's a sole community hospital. So there's the Medicare reimbursements vary dramatically through the state. But when we're trying to compare commercial prices to commercial prices, the standardized price gets rid of that Medicare noise and allows you to sort of look at that. And in that, NVRH this year and last year, this year's is the RAND 5 data. Last year we had Sarah Lindbergh had in our budget tool, the RAND 4 standardized price was noted there, is pretty high.
So I think Andre makes a good point. I think we would like to get a better understanding of how the Green Mountain Care Board wants to look at this data and intends to use it, so that we can better integrate it into our budgeting and thoughts around our overall budgets moving forward. So that's something we could probably take offline and work with you on.
Yeah.
Okay. Yeah.
And I think some of the work we're doing around looking at our pricing, how we compare to the state averages, which is kind of probably more around the RAND standard pricing, will help us probably reduce how we look compared to that matrix.
Yeah, and I think looking at the state averages is helpful, but we have this sort of unique thing in Vermont where most hospitals outpatient pricing is in, if their inpatient pricing is at the 4th decile, their outpatient pricing is at the 7th or 8th decile, 5th decile, 10th decile. There's very few. So we have very high outpatient prices around the state. compared to across the border in New Hampshire, down in Massachusetts, even in New York. Albany's inpatient prices are substantially lower than other states. So I would, just sort of think about that. Maybe comparing to the state average may still put you on a pretty high outpatient price.
Yeah, I think there's some work to be done to understand and how we can shift and move into that direction.
Yeah. And I just have one more question, which was, you mentioned an 86% retention rate of staff. Does that mean it's a 14% turnover rate?
Effectively, yeah.
And are there like, I don't know if a benchmark is the right thing, but regional comparison rates for where my last reading of this was that pre-COVID, 5 to 7% was sort of fairly normal. Then in COVID, academic medical centers up to 30% turnover rates, and now, but I don't know. This is really dynamic, I think. But are you able to compare yourself against regional comparators in this?
We don't have our chief HR officer on today. Ryan, do you want to make a comment about that, or?
I think it's I don't know that there's hard benchmarks. We'd have to look into that and get back to you on that. But I will say that it's a significant improvement from where we were, through COVID, and in a completely different healthcare, environment nationally. So it looks pretty good to me right now, compared to where we were over the past few years.
I think I'll be honest, Dr. Mertman, without looking at data, we have no data in front of us. I'm sure we could all dig up the right data. The 5 to 6% feels low to me. I think currently the national average for healthcare turnover is over 20%.
Okay.
So we were feeling really good about where we're at right now.
I do know that VAS does surveys on this, so there is some internal data available, and I think we're similar or on the low end of turnover compared to other Vermont hospitals. But I'd have to look at that specifically to get you numbers.
That's great. I mean, it seems like it's reflective of along, at least in my view of your hospital, it's only been a few years of really digging through it, but several year dedication to the process. So I think I'm really psyched for you guys that you've been able to improve that, and maybe we'll keep figuring out how to get it better. I mean, everyone should move up there, right? Except for you don't have any housing. The one thing not a question, I just wanted to call out was in your description of your contingency plan if you didn't get the requested rate. I really appreciate the thoughtfulness and consideration of this plan, how it seems to be really focused on trying to identify things that would not impact patient care delivery if this was to occur. And it just seems, I don't know, I appreciate the community focus, the mission driven focus of this plan. So I just want to call that out. I've read several of these, and I just want to say thank you.
Thank you.
And that's all I have for now.
I can go ahead and go next. Hi, everyone. Good morning. Hope you're well. Dave hit on some of the questions that I had, so I think I also kind of structure my questions using the narrative. So apologies if I jump around a little. In terms of, so just for a moment on the pain clinic, it wasn't quite clear to me when your clinician either started or was going to start your new doc. Has that person started?
Yes.
Yeah.
Okay.
Just started.
Got it. Great.
August, this month, actually. Yeah.
Okay. Thank you. Just trying to get a sense of timing there. That one is asked. And thank you for quantifying your expense reduction efforts in your PowerPoint. That was one of my questions in follow-up to the narrative, so that was helpful. In terms of the capital expenses related to the approved CON, in the CON, you had estimated a 0.25 to 0.5% rate increase as a result of the CON. And it looks like in your current budget ask, you're attributing, if I'm reading this right, 0.9%. Is that, am I understanding that correctly?
I'd have to go back and look at that, Robin. That sounds about right, but I'd want to go back and verify it.
If you wouldn't mind, that would be good. It's just, I'd like to be able to try and see how the estimates change over time, particularly in terms of the CON process. And then, Andre, when you follow up, if you could just, if you wouldn't mind explaining sort of it's not a big change, but it is a change. So if you could explain sort of what has changed since your estimate in the CON in terms of the rate impact.
Yeah, if I were to spitball it, I would say probably the operating margin that we have this year is what's impacting that.
Okay. Okay. Thank you. In your narrative, and then also you did mention this, I think, in your presentation, you talked about using your grant funds to offset some operating expenses, particularly around strategic planning and revenue cycle improvement. I wondered if you could just speak a little bit more to how did your revenue cycle improvement go? What's the timing on implementation for those sorts of initiatives? And then a little bit more on your charge master review. Again, what's the timing? When would you expect that to be completed, et cetera?
Yeah, thank you, Robin. We started the revenue cycle review back in, I believe it was beginning of May. We used a company that was arranged through Rural Health Redesign. They did an extensive revenue cycle review on the hospital-based services. And then they came back and did another revenue cycle review with the practices. We actually just started our meetings with them to implement. We've got a work plan in place. It's a pretty extensive work plan. They've met with all areas of revenue cycle. Some of the things are going to be, relatively easy to implement, and some of them are going to take an organizational initiative. So right now that's in place. We've probably got a 6 to 12 month implementation timeline for a majority of it. Some of it may actually take longer. We may parking lot, depending on the complexity of it. So that's where that is right now. I'm really excited about it. Our people who are involved in revenue cycle are really excited about it. A little nervous at the work in front of them, but also excited about it. On the CDM, we kind of did it in parallel because the CDM review is a much deeper dive. And we use a different organization, and we got some SHIP grant funding through John Olson to pay for that. Again, we got that back last week. We got a work plan with it, and we're going to intertwine that with the revenue cycle initiative. We have a revenue cycle committee that I set up probably a year ago now, and we're leveraging that committee to move both of these work plans forward. There are dollars there. Can't tell you the timing of when we're going to realize all those dollars, but there are dollars there. So I'm excited about it. The team's excited about it. Again, a little apprehensiveness on the amount of work with these other things we got going on, because we also implemented a new payroll system this spring as well. So we had a lot of stuff going on in the world of finance. And we got this little thing called the West Wing Project that we're also doing at the same time with USDA. So trying to manage all that change for the organization. It's pretty significant. So we want to make sure we don't overstress it as well.
Yeah, that makes sense. So it sounds like in terms of the dollars related to revenue cycle and the charge master review, that you would expect to see that more in next year's budget. Is that fair? Maybe
Yeah.
some in how the actuals are going.
Yes, absolutely.
And if it happens that things go maybe more quickly than you expect and you get an impact in this year's budget, how would you manage to ensure that you still maintained your NPR targets, assuming it was a favorable impact?
That's a good question. I think our NPR targets may get exceeded simply because we're now collecting money we should have been collecting. One of the things we have done, Robin, through our revenue cycle committee is focus on our denials, some denial management, and we focused mainly on prior authorizations, and we've significantly reduced our prior authorization denials because I don't know if you're aware, if you get a prior authorization denial, 99% of the time you have to write it off, the whole thing. You can't go backwards in time. Through the revenue cycle committee, we've made acute awareness and education through all the departments that can potentially touch a patient that needs prior authorization. So you kind of close the holes in the Swiss cheese. So if the front end misses it, somebody else is looking for it and says, wait a minute, we didn't get it. Or you got the prior authorization and it was for the wrong date or the wrong procedure. So we can go back and review that and get a new prior authorization, therefore not interrupting patient care, which is huge, because if we find it as the patient's at your door, we're potentially postponing that care, but also not interrupting the dollars you get. I would hate that the Green Mountain Care Board would penalize us on NPR because we were more efficient with our revenue cycle.
Thanks.
Because there's no additional volumes or growth there. And I think the management of that, Robin, would most likely be in the following year where we didn't have to ask for as high a fee increase. It would reduce that ask.
Yeah, okay. Okay, thank you. In terms of the rate increase, I want to make sure that I understand the request. So the 4.5% is 5% on inpatient, outpatient, and no increase on professional services. Am I right about that?
That is correct.
Okay, thanks. And that's the net NPR increase, not the charge increase.
That's the charge increase.
Okay, all right. Got it.
And Robin, you understand why we don't put it on the, yeah, okay, just make sure.
Yes, yeah, I mean, you're welcome to explain it, certainly.
No, if you guys get it, that's fine. We don't have to go through it again, but I just, reasons and it's overall better for our patients.
Yeah, I just wanted to clarify because some people are doing one way and some people are doing charge increase. And so just understanding what I'm looking at is important. Great. Okay. Thank you. I'm coming to the end. In looking at your summary statement of revenue and expenses, I was noticing, although it's very small, so it's certainly possible that I'm looking at it incorrectly. It looked like your marketing increase significantly increased in 2024 from projected to budget. And I'm wondering if you could just speak to that a little bit, if there was something specific going on. In the summary statement, the 24 budget was 50,000. The 24 projected was 105 and change.
Well, I won't speculate. I don't know. Doing that deep line item dive is probably hard to do, but we can probably look into that and get back to you, Robin. If I had to guess, and this is pure speculation for the record, it probably was a reallocation of an expense that should have been in marketing that wasn't through the zero budget.
Yep.
Right? That's usually what those jumps tend to be, but it's not like we've radically changed our marketing program over the last year.
Great. Just jumped out at me, so figured I'd
Yep.
ask. So I'm shifting gears a little bit now. So on June 5th, you received notice that your fiscal year 23 budget NPR was over by 1.91%. In that notice, it indicated that you'd have an opportunity during the budget hearing to speak to that for enforcement purposes. And so I didn't notice that in your presentation, and I wondered, certainly I've read your submission on June 11th and what you had said back in January when you reported your actuals in terms of the explanation, but I wanted to give you an opportunity to speak to that further if you so chose, and certainly fine if not, but wanted to give you that chance, and then I had a couple questions.
Yeah, I think I can speak to it a little bit, Rob, and I think we alluded to it a little bit in the presentation or Dr. Merriman's questioning with the volumes increasing in 23 as a result, at least we feel, of pent up COVID volumes. And like I said, our OR cases are in specific relation to that. They were running plus 300 cases a month last year, and they've been running in the 280s this year. So we've seen that come back down, and I do think that it was related to some COVID pent-up demand. As we talked about earlier, the volumes have come down and have kind of flattened and stabilized. So I think 2023 is probably more of we'll call it a COVID anomaly.
Okay, thank you. Also in your June 11th letter, you mentioned that contractual allowances exceeded budget, which you were attributing to eliminating the coding backlog for fiscal year 22 services. I wonder if you could speak to that in a little more depth.
Yeah, I think what ends up happening is when we have a coding backlog, it means charges haven't been coded or billed or accrued for, because we don't know what they are. And
Yeah.
then when they do get coded in the following year, you pretty much have a timing issue. It should have been back in 2022, and now it's in 2023.
Got it. And if you can, could you explain why there was a coding backlog in fiscal year 22? If you know.
I think
It was a long time ago. So.
Yeah, I do know. I do know we had some staffing challenges back then.
Okay. Thanks. All right. That's what I had. Thank you very much for your time, and I appreciate the conversation.
Thank you, Robin. Same here.
Any other board member questions?
I'll hop in with a few. So thank you all for coming, and so appreciate all the work that you're doing. And I so appreciate actually all of what your community is going through with the recent flooding. It's hard to see some of those pictures on the news, and to understand what's happening personally on the ground must be really a huge struggle. So wanted to acknowledge that. I wanted to first also thank you for the zero-based budgeting. So we've been asking about that now for a little bit of the last couple of years or so. And I just really appreciate the extra effort that you all have done to do that. We know it takes extra effort, but for the sake of Vermonters, really going through the budget meticulously to see if there's savings is really appreciated. So I wanted to thank you for that as well. I'm trying to quickly like figure out which questions have been asked and what are left. I do have a couple. So the uptick in CMI that's observed, is that a revenue cycle coding change, or is that a real change in patient acuity in your community, do you think? It's a small uptick, but it was noticeable. So I'm just curious.
Yeah, I don't see any real change in our coding, Jessica. I saw that too, and we continuously hear that the patients we're keeping are sicker.
Okay.
And I always go back to, well, what's our case mix index? And the case mix index kind of supports what they're anecdotally telling us. So I don't see any significant change in our coding. I actually think we do have sicker patients that we're taking care of.
Okay. And did any of,
Ryan,
oh, go
sorry,
ahead.
Jessica, I just, Dr. Sexton may add some color because of his experience in the ED. Just want to give him an opportunity too.
Sure.
Yeah, no, we will keep everyone that we can here. And with the transfer challenges that we've had, I know we've acknowledged that our numbers have ticked up in the past year. But through COVID, especially and coming out of COVID, the challenges with transferring patients is real. And so it is not uncommon that we will call multiple tertiary care facilities within our state and region and not be able to secure emergent transfer and instead have to hold patients who should frankly be at a tertiary care facility longer than we would like, certainly longer than they would like.
Okay.
That's real.
Yeah, and Jessica, if you look at the last 3 years, I mean, it's a trend that's gone up each year. So it's not just the 1 year spike in case mix index. It's gradually going up. So that also tells me and we haven't done anything different with our coding. So that's kind of where I'm coming from on that.
Are there recommendations to change the coding from that revenue cycle improvement study? Is that part of one of the line items of action steps at all?
There's some recommendations to look at CDI, which is improved documentation or more accurate documentation. That may or may not increase the inpatient coding, as well as potentially capturing some stuff that we're doing that we're not billing for, procedures type of thing, which don't play into case mix because case mix is only inpatient.
Okay, got it. And you mentioned that the average daily census is about 15 or so. What do you staff for?
That's going to go back to our zero-based budgeting. We have a staffing model with our nursing areas. And quite honestly, I don't know what level they're staffing for as far as patient days from a census standpoint. That's our next step, is going back and saying, okay, what are our average days? Are we staffing to maximum or are we staffing to average? So that's the next step in our zero-based, quote unquote, zero-based budgeting with our staffing models. But that's a great question.
But so do you know what you've been staffing for? I mean, is that something you can follow up with us with? What have you been staffing for and what's your plan staffing in the future?
Yeah, currently we've actually restricted our admissions to 15. And I think it's what we're staffing for, what our actual staffing is dependent on what we have for staffing. So it's kind of tough to say how many staff did we actually have to take care of the number of patients we had when we're just kind of scrambling to get staff in here. I think once we get these new 8 nurses trained up and are able to remove these travelers, or at least reduce them drastically, we'll be in a much better position to say, okay, what are we staffing for? What's our staff? What should our staffing plan look like? With the mix, with the appropriate mix, RN, LNA, if we have LPNs on the floor, because that matrix can shift depending on the acuity of the patient. To a lower acuity, you may be able to use an LNA, i.e. like a SNF patient, nursing home level patient, as opposed to an RN. So those discussions I think are to be determined once we get that staffing solidified and way more stable than what it has been.
Okay, so there might be some areas of opportunity there in terms
Absolutely.
of expense.
Absolutely.
Okay. Another question on the income statement. It looks like you're budgeting for, if I saw this right, minus 65,000 for non-operating revenue, unless my eyes were not right, but I think that was a minus sign there. The font is really small, but in 24, you're projecting about 3 million on that line. So I'm just wondering if you could talk a little bit about non-operating revenue.
Yeah, the non-operating revenue, Jessica, every place I've worked has pretty much not budgeted or budgeted very little. The non-operating revenue is mainly from our investment portfolio. And if you can tell me what it's going to be this time next year, you can make a lot of money. So we don't know what it's going to be. Some years go up $3 million, and I've seen other years where it's a negative $3 million. So it's one of those, it's for the most part out of our control. So we try not to budget much in there at all.
Okay. And then my last area of questioning was really around some of the clinical productivity numbers that you all submitted. Probably not surprising I might ask about this. So I'm wondering if you can talk a little bit about them, and in particular, how you've used them in the past to address access challenges, and how you may have used those, if you've used those, to think about staffing and increased staffing, hiring providers or not hiring providers. How you think about clinical productivity.
Ryan, do you want to?
Yeah, sure. So I think, Sean, you spoke to this in the presentation. We are focused on this, right? We have right now initiatives on clinical documentation improvement, and I think that depends on how you measure productivity. But if we're looking at RVUs generated, I think that there's a lot of opportunity in how we're documenting, and so we're also currently piloting an AI scribe documentation program in our clinics. We do hope that will both improve documentation, but also efficiency for our clinic providers.
Okay,
go ahead.
Sorry, keep going.
No, I was just going to mention too, we're always exploring creative scheduling, for our clinics, and that's an ongoing project.
Do you have a goal for what you would expect the percentiles to be in your clinics for productivity?
I don't know that we have an established number. Yeah, we traditionally we did not really look at RVUs. It's just not a measure. Now we're starting to take a look at that, frankly, driven by some of your line of questioning. We've tried to focus on encounters and availability and making sure that there was enough access for our patients. They do help, though, as we've looked at it, and we have looked at productivity just differently. We have continued to make incremental improvements, and if you go back over the years, I think you would see that, because they do help drive our decisions around where we need more access. Are we right-sized for our community and the community's needs? It's also informing our conversations as we look to partnering with North Country Hospital on what's appropriate for the entire Northeast Kingdom. So I think this is something that we're going to continue to focus on moving forward, and maybe in next year or future years we will look to set some particular specific benchmarks around RVUs. But again, like I said, we traditionally didn't really use that.
Okay.
Can I just follow up on that too? I practice, and maybe Dr. Merman has experience here too, working in other states and for-profit systems. I was regularly encouraged to move the meat, right? That's how we've referred to patients in those systems. And that approach is really detrimental to patient, quality care. I certainly don't want to see that in Vermont. Many of our physicians, myself included, moved to Vermont to practice in a setting that prioritizes quality care and access. And while I think that there's always work to be done to make sure we're working as efficiently as possible, I think we need to maintain a balance and be cognizant of that balance.
Yeah, I can appreciate that. That's why I was trying to figure out what the goal is in some sense, right? Is the goal to target the median of productivity? I fully recognize to get to the 90th percentile would probably be, as you described, or 80th percentile, something that we may or may not want in Vermont. But, when I see productivity numbers in the 10th and 20th percentile, I see opportunity certainly for increased access, particularly if, in some of those specialty areas where we're seeing 10th and 20th percentile productivity, we're also seeing really long waits at NVRH for neuro, for urology, for pulmonology. So those are areas where the wait times appear long and the productivity appears like there's opportunity. So I'm wondering if, would you agree that there's revenue potential in at least those specialty areas where you have high wait times and relatively lower benchmarked productivity, NPR growth that could come from that, from those efficiency gains and potential AI, things like that.
Well, that is our hope and expectation. That's why we're focusing on it. I will say the measures we typically have used have been around availability, number of visits a day, as opposed to RVUs. So that is something we do look at. We will continue to look at. And like I said, it's a factor in how we partner with North Country moving forward.
Right. So maybe those are some areas where those pilot collaborations might be able to share services and make sense. Okay, those were my questions. Thank you so much.
I just had one question. Page 7 of the narrative, it discusses the budget, assuming a 0 Medicaid rate increase this year. When did you find out the Medicaid rate increase would be 0?
That's our assumption since we have not seen anything different, particularly at the time of budget submission, and I still actually haven't seen anything different to that. And the other thing, just to highlight, we've got probably 85% of our Medicaid lives are in the ACO. So even if it were an increase, something would have to be triggered in the ACO from the target, the initial target, which gets set back in January. And our fee-for-service Medicaid would have a small impact on any kind of increase.
Chair Foster, I'm curious, are you anticipating a Medicaid rate increase? Do you have some inside knowledge that we could benefit from, or?
Unfortunately, I have no control or say in the Medicaid rates.
Yeah, nor do we, but
When do you typically, on the fee-for-service side, when do you typically hear from Medicaid whether there'll be an increase or not?
Many years there's not one. The increases, I think we had a small increase a couple years ago, which was, I want to say, in the July-August timeframe. Because I know it was after we submitted the budget and before the budget hearing.
Okay. And do you have conversations with anyone at Medicaid about the rate increases, like arguing, or not arguing, but advocating for an increase?
I have not since I've been here. I have at prior hospitals.
Do you know, is that typically done through VAWS or individual hospitals?
My experience was individual hospitals with a little bit of VAWS involvement, depending on the situation, whether it was an overall or if it was targeted. Like one of the areas that's heavily in the Medicaid payer mix is OBGYN. So advocating for additional revenue to help support our labor and delivery.
Yeah. Okay. And remind me your payer mix on Medicaid patients. What percentage of your patients are Medicaid?
I want to say 35%. Give me a second and I can tell you. I always look at Medicaid and Medicare together, so.
What are they together, Mr. Bissonette, if you have that roughly, and just roughly is fine for me right now.
Yeah, I've got Medicaid right now at 20% for Medicaid, or just under 19%, and 48% for Medicare on gross revenues.
Okay, well, do you have it? If it's a follow-up, that's fine. I'm curious what it is for the number of patients, not gross revenue.
Number of patients. Okay.
Yeah, percentage of patients that are Medicaid. Yeah.
We can.
Yeah, that'll have to be a follow-up because we don't track that monthly.
So you want the number of patients by payer? Is that?
Yeah, I was trying to get a sense of how great of an impact this is for NVRH that there's no rate increase on Medicaid vis-a-vis other Vermont hospitals, right? Because UVM has a different payer mix, SVMC, than you guys. And my supposition is that you guys are more vulnerable up there to a 0% increase on Medicaid than other hospitals. So I was just trying to get a sense of that.
Gotcha.
Okay, I had no other questions. Thank you all very much for answering our questions and for your time in the presentation.
Can I
If
just
there's
follow
no
up
other,
on
go ahead,
one
Dave.
thing real quick on that? So just when I looked at the commercial, the gross revenue figures for you, I got 47% for commercial, 18.8% for Medicaid, and 33.5% for Medicare, not 48% for Medicare. So is that when you say 48% for Medicare, are you including Medicare Advantage in that? Because that's not on our payer worksheet. Medicare Advantage is not broken out.
Yeah, I think Medicare Advantage may be part of the Medicare because we get reimbursed the same way from Medicare Advantage.
You do?
Yeah, I mean, they're not exactly, but they're to follow the Medicare reimbursement model. So they do pay us at the Medicare Advantage, at the Medicare rates. We give them our rate sheets. One of the differences with them is that they do prior authorizations where Medicare looks for medical necessity. So that's a big difference between the two.
Okay. Are there any, with your Medicare Advantage business, do you negotiate specific rates on any particular codes, or is it all based off of your Medicare billing?
Based off Medicare.
And as a critical access hospital, do you get the cost-based
Correct.
reimbursement as their basis for the, okay. All right, thanks.
Yep. That's part of the negotiation is they want to give us a lower rate and we negotiate up to that.
Yep. I guess just one more question is, if you were to have a bigger drive in utilization than you predict this year and drive more commercial NPR or general NPR, would you consider coming back to the board to do a rate reduction so you don't blow through your NPR target?
Yeah, I'll let Sean speak to this, but I would also want to make sure that there's any, if there were any additional expenses that would factor into that. Go ahead, Sean.
Yeah, I was just going to say, I can't imagine us, I mean, by some miracle, if we increased, my anticipation is that if we did, it would be because we added a provider, right? So our expenses would probably also go up at the same time, and we'd have to take a hard look at that. I mean, certainly nothing's off the table, but you know, by and large, if you look at how we do things, even the efforts we're putting in tends to be somewhat incremental, right? I don't anticipate a radical shift from the budget that we presented. So it is a little hypothetical for us to consider. We'd have to really look at what was driving that and what the costs were that were factored in.
Yeah, I think if we saw like significant commercial increases like through the summer, that we would anticipate carrying through the rest of the year, we would want to have a discussion. To say if we all of a sudden had a spike in commercial volumes, that would increase our NPR, and it didn't start happening till October. Depending on how that timing would run, it would automatically flow into the budgeting for next year. So I would say at minimum, the following year, it would absolutely be taken into consideration. Mid-year, it depends on how that timing would work. I'm just kind of thinking of how that would actually play out. Not that I wouldn't mind see it happening, but that's just how I would see it playing out. I don't know if that answers your question, Dr. Mertman.
That's helpful. Yeah, thanks.
Okay, and I'll turn it to the healthcare advocate for any questions they may have.
Member Walsh, did you have any questions? I don't know if I. Oh,
no,
didn't want to skip over. Sorry if I missed that. Good morning, Sam Peisch, the healthcare advocate. Good to see all of you. Thank you for the presentation. Actually, we do not have any questions. Most of mine were asked by members of the board or answered in pre-hearing. Just wanted to thank you guys for working with our office, particularly in the last couple of days, updating some of your policies on Act 119. So thank you. Back to you, Chair Foster.
Yeah, and Sam, I just want to give a shout out, thank you to you and your office for helping us through the policy, especially with the plain language. That was extremely helpful, and pointing out the changes we needed to make for the application. So I just want to say thank you.
No, thank you. Well, hats off to Emma on our team. I don't want to take credit. It was really,
she did a
really
great
her work.
job.
Yeah, thank you.
Great. We're going to do public comment at the end of the hearing days, so I'll save that. We have nothing else on our end, so thank you all for the submission and the presentation today. We will take a break and we will come back at 12 o'clock for Springfield. So thank you to the NVRH team, and we will take a break till 12. Thank you.
Thank you, Chair Foster. Thanks, everybody. Take care.
Thank you very much.
Have a good day.
Thank
Bye.
you.